We'll go with the Brooklyn pronunciation.
We are live. We'll start at 6.
We are getting live, but before we become live, Dr. Landa, I'm actually from Pompton Plains, so I'm quite close.
Yes, you are. Just a couple of exits away.
So we will begin promptly at 6 o'clock. That's all right with everyone. All right, it's 6 p.m. on my clock, so why don't we get started? Okay, so good evening, everyone. Good evening to our guest panelists and our prospective anesthesia residency applicants viewing on our YouTube live stream. My name is Norbert Smittal, and I serve as the Anesthesia Interest Group, third-year president at New York Medical College. I'm joined with my colleague, Michael Brown. He's our ASA delegate, and Ian Chow, our treasurer. And we're excited to host the first panel in our series of virtual application forms. For those joining us for the first time, we hope to provide applicants with information about the application process, learn more about the wonderful anesthesiology residency programs joining us today, and answer many of the questions that you may have. Before we start, I want to foremost thank our guest for joining us. We're joined by Dr. Seth Landa, Residency Director, Program Director at St. Joseph Hospital, Department of Anesthesiology. Unfortunately, Dr. Mala was unable to make it today, but we do have future events with more program directors, which we will advertise at the end of this event. So we also want to thank our faculty advisors, Dr. Abramowitz and Dr. Weber here at Westchester Medical College. They have supported us behind the scenes to be able to run these virtual forums, as well as all of our events throughout the year. We would like to invite our participants to join us on slido.com. The link should be in the description. You can ask questions there, vote on which questions you'd like us to ask at this panel and for future panels. The link is in the description. So first, I'd like to give Dr. Landa 2 to 3 minutes to introduce himself and the residency physician joining them with a brief overview of the program before we get into our submitted questions. The moderators for this event will be Michael Brown, MS4, and Ian Chow. So take it away, Dr. Landa. Thank you very much for being here.
All right, pleasure to be here, and thanks to whoever is watching for joining us. I love a captive audience, although it's really not a captive audience since anybody can leave the meeting anytime they want. So I'll try and keep things moving along as best as I can and entertain everybody as best as I can. So yeah, my name is Seth Land. I'm the program director. I've been at St. Joe's for 33 years, and I've been program director for at least 20 of those years. My residents started referring to me as the PD before I even knew what a PD was, because I was just doing the job already. So they assumed I was the man. But certainly since about 2000, I've been the program director. The chairman at our department is Dr. Stephen Winikoff, and he's also been there for over 30 years. And we've been running the program together for, like I say, for about 23 years. St. Joe's, first of all, is the oldest program, anesthesia program in New Jersey. It's been training residents since the 1950s. I haven't been there that long, so that makes it about 70-something years old. So it's a very well-established program. We have 24 residents, 8 per year, which makes us kind of a mid-sized program, which is very comfortable feel. We have 2 hospitals, St. Joe's, which is in Paterson, that's the main hospital, and St. Michael's, which is in Newark. So those are two of the three largest cities in New Jersey. And that just helps to inform you a little bit about the number of cases and the type of cases that you're going to see. Both very busy cities, both very busy hospitals with great diversity of cases. Everybody starts at St. Joe's. Everybody spends about 2/3 of their time at St. Joe's and 1/3 of their time in Newark at St. Mike's. And again, they're about 20-25 minutes apart. So really geographically, not a big deal. The first thing I want to say is just, I want to dispel the notion that a lot of students out there might have, that you can only get really amazing quality training at a primary medical school affiliated program. We have medical school affiliation, but we run all our own residency programs, and you can get amazing training at St. Joe's. St. Joe's is a major tertiary care teaching hospital. It has a university designation. I always thought university was just something anyone could slap onto their hospital to make it seem like they're academic, but it's really an earned academic designation that has to be awarded to your hospital. So we are St. Joseph's University Hospital. We have residencies across the board in just about every specialty, medicine and surgery. We are a trauma center. We are a children's hospital. We are a high-risk obstetric center. We are a stroke center. Both St. Joe's and St. Mike's have open heart surgery. So these are major institutions where you're going to get all you need out of training, amazing training, ability to do research. We have a very vibrant IRB and a lot of good research coming out of St. Joe's. But at the same time, I got to say, it has a little bit of a community feel to it. It services Patterson, it services the surrounding areas, and does a lot of good within the community. And it has a little bit of that community hospital feel where you just get to know everybody. From the time you walk in the morning and you say hello to the guard in the morning, at the Willie at the front desk, and then you go to the cafe, and you'll know all the people. Let me just ditch that phone. Sorry. You'll know all the people in the cafe and the housekeeping people. So it's got a little bit of this community or family environment, which I think is great. And I've actually had our medical student rotators comment to us about what a friendly place St. Joe's was for them, as opposed to other hospitals that they've been to. So it's great that it retains that to a tremendous degree. Being in Patterson, being in Newark, great cultural diversity. Patterson itself has about 40 different ethnic groups within it. And we also service all the surrounding suburban areas. So you've got this amazing, like this socioeconomic diversity as well, where we are servicing the wealthiest people who live in New Jersey, as well as the poorest people who live in New Jersey. So it's quite the dichotomy there. The other thing I just want to say is we have a great faculty consisting of both, some of the OGs like myself. By the way, OG to me just means old guys. So we got a few of us like myself and Dr. Winikoff, the old guys, but with the experience. And then we've had great, and I think we're blessed with this because it's been very tough in anesthesia. Staffing has been very difficult over the past few years. And over the last year or two, we've been able to hire an amazing faculty, young, talented, fellowship trained, enthusiastic attendings, subspecialized, who just have honestly energized our teaching program. And these are the people that are going to be there for years to come. So I think that it's just been an amazing transformation within our department. So in short, I'll shut up and let you guys ask questions, but it's a great place to train, and it has everything you could want out of your training from a major institution in a little more of a communal or family feel to it.
Okay, shut up.
Okay, well, I just want to say good evening to the almost 50 viewers we have watching us. My name is Michael Brown, and I serve as a delegate to the ASA medical student component, and I'm joined with Ian Cho, the treasurer of New York Medical College's AIG. I just want to say thank you to Dr. Landa for joining us today. And to those who were expecting Dr. Michael Mala from SUNY Downstate, he had to cancel today before the meeting, so I apologize for that. And before we get into the questions, I also want to invite everyone to join us on slido.com with the access link NYMC-AIG, where you could ask questions and everyone votes on those questions, and you could have Dr. Landa answer them during this talk. So without further ado, thank you for introducing yourself, Dr. Landa, and your program. The first question I have for you today is, what about your program are you most proud of? And are there any areas you have identified as not as strong and you're working to improve?
Wow, love that question. So what am I most proud of? So first of all, I'm proud of what my graduates have accomplished when they leave the program. I see them out in the real world. I follow them all across the country. Now it's great with social media and whatnot. It's so easy to keep in touch with them. And they've accomplished amazing things. So many of them have become leaders, educators, and have, people who started their own surgery centers, people who run departments in hospitals, people who are, fellowship directors at various hospitals. So that's such satisfaction, such pride that comes with that. And at the same time, they're proud of their training. I mean, they love their training. And again, point of pride. If these people loved where they trained, are proud to say that they were St. Joe's grads, and can tell me that they loved their time at St. Joe's. Just the other day, I was talking to somebody, one of my grads, honestly, from 33 years ago. He was the very first resident that I had on rotation on OB. He showed me where the cafeteria was, so this guy, we got in touch, and he just said, I had an amazing time at St. Joe's. And I think that's, again, something to be proud of. And really the type of atmosphere that I'm trying to maintain is one where you will leave and feel proud and happy that you trained at St. Joe's. We have the ACGMA faculty resident survey that they fill out every year. And the very first question on the survey for the residents is, would you definitely choose this program again? Would you probably choose this program again? And then from there on, it goes down to, well, maybe I choose it again. 90% of my residents answered one of the top two. Either they would definitely or probably choose the program again. And again, that's something to be proud of. So that should answer that part of the question. What was the other part? Things that were not as strong. So, I'm just trying to think that it's a tough one to answer. Things change on a year-to-year basis. We can have we just had a busy thoracic surgeon leave, and I'm waiting for them to replace the thoracic surgeon. So, there are little things like that, but overall, I think the program is in great standing. Something like, let's say, research. We have so much research material, but we're so busy. So you really have to scrounge to get your research time, which we do. We make do, and we actually produce some really good and excellent research projects. But, I wish I had more time to kind of, involve more people. So those are important things. But overall, I would say there are no glaring weaknesses that I would have to work on.
Thank you so much for that answer. So my next question would be, you've been in the program director for over 20 years. Can you speak a little bit to how your program has evolved over this time?
Sure. Yeah, I mean, that's a great question. Wow. Again, so many things have changed, and the practice of anesthesia has evolved, and we change as a department as anesthesia changes. We're very fast to incorporate new techniques, new ideas. We picked up, peripheral blocks very quickly. And we saw and totally appreciated the importance of peripheral blocks. We picked up the idea of, if you've heard the term perioperative surgical home, where you're just trying to take care of the global patient from the beginning of their surgery to the end. And, we've applied that to a lot of our different, surgical specialties, whether it's colorectal surgery, GYN surgery, major orthopedic cases. We've adopted enhanced recovery after surgery protocols. So really, we evolve as the field evolves, for starters. Another just amazing thing, which if you would have told me this 25, 30 years ago, the hospital totally underwent a reconstruction, built a new building, built new ORs, built ERs in about, I think it opened, I'm thinking in 2011, 2012. And so it's really become a spectacular hospital. I mean, you don't realize what you're missing until you have it. But, 30 years ago, if you would have told us that our hospital looks the way it does now, I would have never believed it. And so, we've just advanced in terms of even our appearance, and just the grassroots, walking down the halls, you feel like you're in a nice, beautiful institution. So the hospital has evolved as well. And in the services it offers, it's become a stroke center. It has always remained, a major pediatric hospital, major obstetric hospital, trauma center with that. Now it's got the helipad, was part of the construction. So, yeah, I think we've evolved, physically, and I think we've evolved again as anesthesia has evolved as a specialty.
Thank you. And for the next question, as we enter year 4 of virtual residency interviewing, what have been the biggest takeaways on how the shift to virtual interviewing has affected the interview process?
So, when it first happened, of course, everybody had great trepidation about this whole Zoom thing will work. I will tell you, and look, you're all watching me here. I have no idea how I'm coming across. I hope I don't fall into the Great Falls of Patterson here. That's behind me. But talking to you over Zoom is not that much different than talking to you over here, sitting in a chair. I don't get the wet handshake. That's great. But, I think the interaction is favorable. I think from the student standpoint, you could be in a comfortable environment, at home or, in your dorm, wherever, and you can have a little drink there and you don't even have to be wearing pants. I mean, it's like you could just kind of chill and be very comfortable. So I think it's advantageous in that regard. And of course, man, the monetary saving, and it's just so much easier this way. So I think it's here to stay, and I think we're lucky for it to be this way. I do understand that some people would like to see the hospital, would like to see, to get a feel for the program. That for sure is missing. You get to meet a limited amount of faculty, and we'll have, I know, maybe we'll discuss a little bit, some of the other things we do on our interview day, but I think we reproduce it, virtually about as well as we can, and the advantages just can't be beat.
Great. So Dr. Landa, I just have, I'm going to start asking questions instead of Michael, just go back and forth. But one of the questions that we had was, with step 1 transitioning to pass fail, what is kind of the metrics that you're going to be looking at when you're evaluating application?
Well, there's a darn good question that every program director in the nation is going to be dealing with. Look, how much did I value, or do I value, the step scores? You're going to have a lot of program directors for the next few weeks coming on and say they will do a holistic. You're going to hear that word a lot. They're going to do a holistic review of every applicant. And it's true, we do a holistic review, but at the same time, any program director who tells you that they don't have or place importance on a grade or on grades is just not really being totally honest. I mean, I don't want to be completely disingenuous about the whole USMLE thing. Of course, it's important. And now that shifts very much to the step 2. I think every program will have their own kind of mental cutoff, though none of them will admit to a specific cutoff. Everybody has their own, kind of area that they would like to see you. So yeah, I think things will shift a little to the step 2. I think that I will be doing a little deeper dive into, those schools that provide any type of grading, ranking. I mean, there has to be some way to establish, a degree of academic excellence. Yeah, sure, other things count as well. And yes, I do a holistic review. But everybody participates in the 5K run for breast cancer. I mean, everybody does those things. So how much of that really speaks to the candidate is a little difficult to say. So I think, any survey of program directors that I've ever read has scores and grades near the top of the list. So yeah, I think it shifts a little bit to the USMLE step 2 and to those that provide grades. It's good to see a little H here and there scattered on, on the schedule, or at least an HP perhaps for a high pass. But even that's becoming scarcer, as a lot of American programs certainly were pass fail. So it's tough. I'm not gonna lie to you. It's tough. Obviously, well, I mean, the good thing is there are tons of good candidates out there. So I don't think we can go wrong.
So talking about with step 1 being pass fail, unfortunately, step 2 having such a strong, being such a strong metric, especially now. And sometimes the step 2 score might be sometimes a deterrent for some applicants. How would you, would you have any recommendations for these applicants that, let's say, step 2 has not gone well for them?
Well, if there's a particular reason that you think step 2, so, when step 1 wouldn't go well and step 2 is there to compensate, I'd accept that. And I accept that somebody can have a bad day for sure. I can also accept that somebody can learn how to study better. I don't know, when you get your step 1 result, does it come back to you as a pass fail, or do you still get a score?
It's just a pass fail. There's no score.
It's just a pass fail, because at least if you got a score, you could at least kind of get a feel for where you need to go studying wise for step 2. Step 2 being more clinical is the more meaningful exam ultimately. But yeah, anybody can have a bad day, and certainly we accept that. And I might see a certain dissociation between academic excellence on a transcript versus academic excellence on a single exam. If somebody wants to reach out to a program director, I always encourage it with whatever, if they're not getting an interview at a certain place, reach out. I read every single, I don't want to tell this to everybody, but I read every single email that comes my way, or if it goes to my program coordinator, she sends everything to me. I read every single email and I will consider anything strongly. So it can't hurt to reach out that way. If you have some, reason that you might be able to give for why you did not succeed, or why you think it's a less important aspect of your global application.
I know that you mentioned how certain programs have cutoffs for these types of scores. Does your program in particular have any cutoffs for step 2?
So yeah, no program will admit to a number. I will tell you that. But what I'll usually look at, to be honest, is whatever the average was for that year. And that's a starting point for me. That's a starting point. I might look at people who are like slightly sub-average, certainly obviously being above average is going to help. But, every year there's a mean, and that's kind of going to be my starting point. I don't want someone who just barely passed by, a point or two. Yeah, that would kind of be a little bit of a rule out, to be honest.
Thank you for that transparency and answering all those little details. I could speak for myself and say that this is something that I've been worried about with this new change without step one. So my next question for you is, how does the program respond to resident feedback and suggestions?
Yeah, so man, I sort of wish my resident was here to back me up on this, but because obviously I could tell you whatever I want, but listen, I live to serve, and I want my residents to feed back to me anything that's on their mind. And we have a really open program, and we have a great relationship with our residents. Dr. Winikoff, our chairman, I'll speak for him as well. He's got an office just kind of right next to the anesthesia conference room lounge where everybody hangs out. His office is always open. People just can walk in there, chat with him, ask him any question they want, talk football, anything they want. He's just very open, and you don't have to make an appointment to see him. He's always there. Me, since I'm the OB guy, I'm open all the time. You just have to follow the screaming pregnant women and you'll find me. But we're both very open to suggestions, and we listen. I'll give you examples. I think I can give you some concrete examples if you want.
Dr. Landa, I'm here, by the way.
Hey, Dr. Patel Saurabh is here. How you doing?
I'm good.
I just want to introduce my resident. This is Saurabh Patel, who hopefully will back me up on everything I'm saying here. Do you want to ask him the question?
Yes. So Dr. Patel, the question I asked was, how does the program respond to resident feedback and suggestions? And I guess another follow-up question I could ask after that is, are there instances where a program has changed in response to that feedback?
Yeah, so I think overall the structure of our program as a whole is really great. It operates well. A lot of things work out for the most part. Whenever the residents have suggestions to change things around, we always talk to Kathy, our program coordinator, and Dr. Landa, because they're the two people who kind of set things in motion for us. Last year, one of the things that they got for us was a subscription to TrueLearn, which we didn't have to pay for. They got it for us, and we were able to use that question bank throughout the year to help us prepare for basic. Other little changes, kind of like in the day-to-day, like there have been changes to our SA anesthesia record keeping system to kind of help streamline things based on suggestions that the residents have made that they notice could help make things more efficient. Order presets, things that we can work with IT on to kind of help our lives run a little bit more smoothly. And then like day-to-day stuff, like, Dr. Landa got us a coffee bar because we were like, we're spending too much money on coffee. Is there a cheaper alternative? So he set us up with a Keurig and an espresso, and like right in our library, and it's funded with like pods all the time. So we got a coffee bar. We've made call room enhancements based on things we've wanted. Our attending call room is awesome. There's like a Mac in there, a TV, so you could lounge in there. You could look up your patients. So we wanted some of that too. So we've been working on getting things like that done as well. So they're very responsive. They're open to hearing about how we can make the program better all the time. And it's just, like Dr. Landa said, open door communication at all times. We can just stop in and chat no matter what the time of the day is.
That's very good to hear. I have an espresso at home and I love it. So that's definitely a plus for the program. So my next question for you is, I know you said that you are the director of obstetrics. What types of cases should a resident expect to be involved at your program? And how are the cases split between the residents and fellows?
Is this for myself or this is myself, right?
Yes.
So cases involved when? Was that an on-call question or was that a general question?
Just a general question.
General question. Okay, so the CA 1 year primarily is going to be a lot of basic cases. However, we do also have the CA 1s rotate through obstetrics as first years, because honestly, that's where you're going to get all your spinal and epidural skills, which are fundamental skills for the main OR as well. So spending a month with me, even in your CA1 year, will not only teach you basic obstetric anesthesia, but it's going to get you ready for your orthopedic cases when you want to do spinals and epidurals on your orthopedic cases. So we consider that fundamental. Most of the subspecialties are PGY, are CA2 rotations. Pain, you will be doing all 3 years, each with a little bit of a different flavor: acute pain, office-based, chronic pain. But there's some overlap there, interventional, kind of regional pain, but there's a lot of overlap there. So pain is across all 3 years. Peds is a second-year rotation. Open heart is mostly a second-year rotation. We actually scrolled it back a little bit into the end of the first year. And that was another thing. So to speak to your other question about resident feedback, and I had complaints that some people were doing cardiac so late in their second year, they couldn't make a decision about whether they wanted to do a fellowship or not. It was like, you have to think about these things early. So based on their feedback, we scrolled it back to April, May, and June, so we could get the ball rolling so that everybody would be able to make a rational decision about whether they want to do a cardiac fellowship or not. So OB would be covered, pain would be covered, peds. We have enough peds that even if you haven't done a peds rotation, on call, you will get a taste of peds, throughout your training, even as a CA1, neuro the same. So this way people can make rational decisions about what they enjoy from a fellowship standpoint. So so again, that's kind of the way we work some of the subspecialties within our program.
Okay. And then the next question I have for you is, how will the program signaling and regional preference be used in application considerations at your program?
Okay, so that's also an evolving, changing, every year it's changed a little bit. So the signaling is a nice thing. I think it's important. It's good that we expanded from only 5 signals to I think you have a total of 15 signals now, and there are gold and silver. I don't know, do they have bronze? I have no idea. But it's a good starting point. I mean, I look at the people that signaled us as a starting point, but not as a finishing point. In the past, but prior to there being signaling, prior to there being Zoom interviews, it was interesting. I would throw, invitations for interviews out to people from different parts of the country. And, there wasn't necessarily an indicator on their application that they wanted to be in New Jersey. And if they accepted and came for an interview, man, if you're flying from Oklahoma to New Jersey, I assume that there's a chance you would actually come to the program. And sure, over the years, we've had people from Washington State and Oklahoma and Kansas, Texas, Florida, all over the country. Now, the signaling, I think, will replace some of that. The geographic preferences replaces some of that, although they're very kind of generic. You can say, yeah, I would like to be in the east, west, north, or south of the United States of America. And it's kind of generic a little bit, or saying you have no preference at all geographically. That's another way to get around it. But in the olden days, I would scour ERS applications for any mention of New Jersey for sure. And New York was close enough. So now I think the geographic preferencing kind of saves me a little bit of that, scouring through. So anyhow, signaling, good starting point, important starting point for me. Geographic preference, I think increases the likelihood of somebody wanting to be in our program, but doesn't rule it out. And I will not restrict myself to those geographical preferences. If somebody out there wants to say no geographic preference, that would be fine as well.
Great.
And I
sorry.
think you also mentioned the supplemental. I'm sorry. You mentioned the supplemental as well. I don't know. I'm going to have to look at it a little more closely. I think all the information that is in the supplemental was in the ARIS application in some form already. So I don't know what it necessarily adds. Sorry for all of those of you out there who are working on your supplemental applications, please do it. And it does help to crystallize what you consider are the more important things. So just don't drive yourselves crazy.
So Dr. Landa, we previously before talked about like the things like that are super important, like our board scores, your class rank, if that's part of your school. What are kind of like the intangible things that you would find in an applicant that really stands out to you?
Well, obviously, so if you mean on paper, so on paper, that's a tough one because it's very hard to do. I mean, maybe there are places that have amazing resources, but I like to go through all the applications kind of myself. And it's very hard to go through with a fine-tooth comb at over 1,000 applications. And that's, kind of a lot. So some of those intangibles don't come through really till an interview or till anyone that I'm going to interview, I will give a close look. And obviously the night before, I'm going through the application with a fine-tooth comb to look at, flesh out the personality a little bit, look at what other things this person has done in life. And when I get to that stage, there are things. So I know I'm sorry for those of you who are part of the Susan Komen 5K breast cancer run that everybody does to try and put on their application. But, then there are people out there who did, Teach for America and spent a year in some, urban area. That, or 2 years, that is impressive. People who went on medical missions all over the world, not just, nice little vacation in Dominican Republic and they spent a couple of days, whatever, but who went on serious medical missions, those are things that do speak a little bit to me and do speak of the, help to flesh out that person's, commitment and what they're interested in. So there are many things that do resonate with me. And I find musicians are, driven, and I find athletes are driven. And so there are a lot of things, but for those of you who are neither musicians or athletes, don't worry about it. There are other things, don't worry about it. So I think there are a lot of little things, just tell us who you are as a person. And, that goes a long way. The personal statement, you're all going to agonize over the personal statement. Again, that's something I'm reading once I have made my decision. I've rarely used that up front as a decisive factor. But it does, serve as good fodder for an interview and to learn a little bit more about you as a person. But it's impossible to read 1,000 personal statements.
Yeah, thank you for sharing that. On the other side of the spectrum, what are some red flags that you see in applicants that you're kind of like, this is not an applicant that we want to see?
Well, committing a felony is probably not a great thing. It is one of the check marks on your application. Have you been arrested? Do you have a record? I remember, one of our chief residents, when he was in college, hit a golf ball through an apartment window and was arrested, and he still wound up as chief resident. So, but a felony, all right, that I might draw the line somewhere around there. Look, in terms of grades and things, I told you, certainly failing a step exam, that would be major. And mind you, you know what? I've taken people into my program in the past who have failed, had a reason for failing, and then did exceptionally well the next time around. And for the most part, we've had success. So there's not that many things I will totally rule out a candidate. But those are certainly red flags that would need explanation. But sometimes, again, within your personal statement, or you have, or even on the front page of ARIS, you have an opportunity to explain anything straight right up front. So obviously those kind of things, the grades things, and getting thrown in jail. Those are the two big ones for me.
Sounds great. Thank you for sharing that.
Oh, wait. Eagles fans need not apply. No, I'm only kidding. I'm only kidding. Sorry, Eagles fans, it's okay. It's a Sorab. I don't know. No. I have an Eagles fan in my program right now. I felt very bad for him as we were on call for watch the Super Bowl together, and I watched him suffer through that. But
So the next question is for Dr. Patel. Could you talk to me a little bit about your typical day at the program? And do you feel that there is enough structured and unstructured learning opportunities?
Can you guys hear me?
Mm-hmm.
Okay. So yeah, my typical day, it all depends on if it's a lecture day or not. We have lecture 3 times a week. And so on a lecture day, I typically get in around 6 o'clock in the morning, set up my room for the day for whatever case I'm going to be doing. And then we get to lecture around 6:30 for about 30 minutes. And then around at 7 o'clock, we go to pre-op, see our patient, do our intake. And then we roll into the ORs around 7:30. Our typical day, usually we're doing anywhere from 2 to maybe like 5 cases, depending on what you're doing. Same day surgery, maybe a little bit more, depending on like pediatrics or like quick dental cases, things like that. Typically, I'd say we wind down around 3 to 4. We check to see if there's any sort of pre-ops that need to be done on any inpatients for the OR for the next day, any PATs or charts that need to be reviewed by the pre-admission testing nurses that they flag for us. And then, we typically go home around like 4 or 5, somewhere around there. We do have a pre-call system where, if you're on call the next day, we try to get that person out. Usually around 1 or 2, not always guaranteed, but it's a nice little perk that we have to kind of treat ourselves and give us a little bit more time since we're going to be on call the next day and you never know how busy it can get.
Mm-hmm.
Post call days are always off. Like you start at 7 o'clock in the morning, your shift ends, and then you have 24 hours off until you're back the next day. As far as learning, so structured learning, we're always learning in the OR as we go. A lot of our attendings are constantly teaching us in the OR and how to refine our technique on, managing physiology, pathology in the OR. And then, like I said, we do have lecture 3 times a week where we have specific topics that we come up with. And then, we read a chapter in Morgan and McHale or some other relevant textbook, and we come in prepared to talk about it. And an attending usually heads the discussion for that lecture day.
Another question for Dr. Patel. This one was fielded from the audience.
Michael, can I just interrupt for 1 second? Any question you have for Dr. Patel, ask him now, because I think they need him back in the OR in 15 minutes.
Yeah, they do.
Okay.
Okay. Do you feel like you get enough exposure to thoracic cases and craniotomy cases to be competitive in the job field once you finish residency?
So I just turned CA2 about 6 weeks ago. And I think even before that, I'd hit all my cranial numbers. I think I was in a little bit of a unique position because they started me off early managing craniotomies, craniectomies. So I hit those numbers pretty early. I haven't done cardiac or thoracic yet, so I can't speak to that, but I know a lot of the seniors have already hit their numbers. And they do feel comfortable going out into practice and managing those cases if they ever get put into one. I would say we get probably some more cranial numbers than thoracic. But either way, like the volume that we get for both, I think a lot of the residents come out feeling very comfortable taking on those cases solo.
Okay, and another question from the live chat. Can you elaborate on your experiences during your PG1 year?
Yeah, PG1. So I have a unique journey. So I actually did 3 years of general surgery before I switched over to anesthesia. So my PGY 1 year was actually a categorical general surgery program. And as you can expect, what a surgery program entails, it was exactly that. So, but I know a lot of my co-residents, they did either medical or a surgical year as well. St. Joe's has, I think, 2 spots, prelim spots for surgery years that you can kind of tie into the anesthesia program here. I think it's a pretty good relationship that you build with the surgeons here because of that prelim year. Like, so when you actually start as an anesthesia resident, the surgeons, they already know you. And they kind of have a sense of trust that's already established because of that rapport you built over that first PGY 1 year. And then having said that, I mean, every prelim program everywhere else is going to be different. Your experience is going to vary based on what you see and what you can learn from those programs.
So going back to Dr. Landa, with anesthesia in general becoming such a competitive field, how much weight do you have for research experiences for new and upcoming applicants?
So you mean not for the applicant or within the program?
So how important is research now for the application process for your program more specifically?
Oh, so okay, so I understand. So yeah, I mean, I think research is a plus. Is it a necessity? No. I think that, you know, involvement in research, especially related to anesthesia, shows again that you're just involving yourself. It's just another means of involving yourself in, you know, immersing yourself in anesthesia to a little bit greater degree. As I mentioned, as a program, we do some excellent research. So it's not like a make or break. But it's definitely something I do consider. It's not like a game changer, but I definitely consider it for somebody who's done extensive research in anesthesia.
Okay, great. And in terms of postgrad for the residents that you have at your program, what do the fellowships matches you typically look like?
So that would be another point of pride for me and for us, which is that historically and currently, we do really well in our fellowship matches. Everybody gets usually one of their first 3 spots. And that goes for basically, you know, all the fellowships. I will say that probably the most popular fellowship coming out of St. Joe's has traditionally been PEDS, because we are a major children's hospital in the area. We do a lot of great PEDS. Either you like it or you don't. You know, some people don't like kids, but you know, you get a great PEDS experience here. Our PEDS attendings are really wonderful to work with, and I think, you know, you develop that kind of mentorship relationship where people get excited about something. Open heart is another big one. Cardiac, we've produced a lot of good cardiac people over the years, and we just rehired one of our grads who went off, did a cardiac fellowship, came back, and is now, you know, teaching for us. We've had a smattering of OB, ICU, a lot of regional. Regional has taken off, and you know, we've had a ton of our residents go out to do regional anesthesia fellowships. And pain, you know, pain has gone through, it was very popular at one time. It was almost impossible to get into at one time, and we were still able to get people into pain even during those very tough years. Now, with the job market the way it is, people are trending away from fellowships a little bit, but that'll change from year to year. But we've had great results. We've had programs that, because they were impressed with our first and second grad, will just continually take our grads. And, you know, one comment I did want to make, we don't at St. Joe's offer fellowships, although we have enough subspecialty training that we could offer fellowships in any of those subspecialties, yet we don't. And I actually want to keep it that way for a reason, which is, you know, somebody like Sora, who just told you that by the beginning of a CA2 year has already done X number of craniotomies, you become the fellow. I'm not going to say a CA1, he might be an exception, but as a CA2 or certainly as a CA3, you are treated as a fellow. You're going to be doing fellowship level cases, whether it's OB, peds pain, cardiac, neuro, whatever it is. You're going to be doing things that some of your colleagues at other institutions might not be doing. My residents who are fortunate enough to be with me over the last few months on OB, we've delivered 2 sets of quadruplets in the last 4 months. I've actually done 1 set of quints in my life. We've had a separation of conjoined twins in the pediatric area. So, we do some really great and kind of crazy cases. And anyhow, it's my residents that do all of that. And so I think it makes you such a stronger candidate coming out. And I think fellowship programs actually do appreciate that. And when you go to an institution and you say, oh, I did X number of necrotizing enterocolitis, and I did a couple of peds open hearts and whatever, they're going to say, wow, our senior residents don't do that, let alone our fellows. So I think it's a great plus for our program to give you guys the fellowship training experience without fellows interfering.
Wow, those are amazing cases. Quintuplets and conjoined twins, those are very cool cases. One last question for me is that for applicants who are DO students, how much do you consider COMLEX scores if an applicant has a COMLEX score 2 in addition to step 2?
Yeah, so I consider COMLEX honestly as the same way I consider USMLE. We have a long history with DOs, and one of our schools that we're affiliated with is Rowan Medical College in New Jersey. So their students rotate with us. Sorry guys, they replaced the New York Medical College. You guys did about a third of your class would rotate through St. Joe's to do your cores. So the hospital flipped and went with Rowan for whatever reason. But anyhow, so I'm used to the COMLEX, and I treat it pretty much as I treat the USMLE.
Great, thank you.
So thank you, Dr. Landa, for answering all these questions for us, and Dr. Patel. I think we went through all the questions that were submitted online and most of the pre-recorded questions we have here, and we're leaning on towards an hour. So I thank you for answering many of the questions that the prospective applicants had about this year's residency cycle. And I wanted to give you a chance to highlight anything about your program specifically that we didn't have a chance to talk to yet before we conclude the event.
Okay, sure, thanks. Well, the first thing that pops into my mind and why we're using Saurabh while he's on call, and it just speaks to the program a little bit, which is when I first, as I told Michael, when I first booked this date for this conversation, for this virtual meeting, I was unaware of one very important fact, which is tonight is our program's fantasy football draft night. And a number of our attendings are taking out basically everyone who's not on call, right? Except for poor Saurabh is sitting there. But everyone who's not at call is at a bar right now doing a fantasy football draft. And if you're not into fantasy football, you're into the other things you can do in a bar. So we have a good time together. You know what? I want people to enjoy their training. And, it should be exciting, it should be challenging, but we're very concerned with resident wellness. We want you guys to have a good time, to look back and say, this was a good 3 years. And so anything we could do to make that happen, we try. So tonight is fantasy football at a bar night. Last year we had an axe throwing night, which was kind of great. Saurabh was a beast. Oh my God. We have a golf outing during the year. we have an amazing welcome party for our new CA1s coming aboard in one of our attendings. Beautiful backyards. He has a swimming pool. Families are welcome. Play a little flip cup. I mean, there's all sorts of stuff going on there. Sorry to keep coming back to drinking and alcohol. That's bad. But anyhow, so we just try and have a good time together. We have a great holiday party. We do stupid stuff at the holiday party. Traditionally, we've had videos that the attendings make, kind of, I don't want to say spoofing or parodying, we'll call it honoring the graduating residents. And then they do the same to us, and we show that at the holiday party. It really becomes a highlight of the holiday party. I was stupid enough to venture into the rap music field for our last couple of parties. So anything, honestly, to make things fun and enjoyable. All our CA1s passed the basic exam. So we had a pizza luncheon in honor of the CA1s passing the basic exam. So, a lot of concern for resident wellness, want you guys to enjoy. And all of those things all serve to bond us together as a team and to create that team culture across the board. CA1, 2, 3, you're in different years, but I want everybody supporting everyone. I want you to know the attendings have your back. Hope my residents have my back, not with a knife or anything. But I think we've succeeded tremendously in creating that kind of an atmosphere. So it's pretty serious training. It's tough. It's hard. Anesthesia is a very challenging field. It can be very stressful, and we just want to alleviate that stress and make sure that you come through smooth.
Okay, thank you so much. And just a few closing words before we wrap up. Huge thank you so much, Dr. Landa, for speaking tonight about all these different topics and about sharing about your program. This was a very personal feel to some events that we've done in the past. And I think this definitely highlights your program very well. An additional thank you to Dr. Patel for joining us as well. And I hope to everyone who tuned in, that you learned as much as I did tonight about this program. And this is the first panel in our series, so look out for emails in the future. And thank you again, Dr. Landa and Dr. Patel.
Small panel, but anyhow, we got to start somewhere, right?
Yes.
All right. Take care. Thank you, Michael.
Thank you so much.
Thanks, Aura.
Thank you.
To our viewers, I just want to make a big thank you to everyone who watched and submitted those amazing questions. And I want to discuss future events that we are hosting. So September 6th, 6 p.m., we're going to be having the program directors from Montefiore, WMC, and Mount Sinai West coming, September 6th, 6 p.m. And September 20th, we have Hofstra, Stony Brook, and Hackensack, 6 p.m. on the Zoom link or YouTube link. So we invite you to join us there too if you are interested. Thank you so much.